All right, let's just dive right into this explainer. Today, we're building a totally fail-proof audit framework to cut straight through the notoriously muddy clinical noise of rheumatology. You know the drill. A patient presents with a bunch of vague overlapping symptoms, and it is incredibly easy to get distracted by the loudest complaint. But today, we're acting as clinical auditors. We are going to literally separate the meaningless noise from the definitive high-stakes signals. Let's get to it.
So here is our docket for today's audit. We're looking at SLE versus systemic sclerosis, polymyositis versus dermatomyositis, PMR versus fibromyalgia, and finally, a crucial Sjogren's pearl. Module 1, the systemic kinetics. We're starting off with a classic 50-50 clinical dilemma. We're jumping to conclusions based on sensitive but highly nonspecific labs can lead you dangerously astray. Picture this. A patient presents with joint pain and Raynaud's phenomenon. Their fingers turn white, then blue, then red in the cold. So you immediately order an ANA test, and bam, it comes back positive. But here's the trap, guys. A positive ANA, that's just noise. It's super sensitive, sure, but completely nonspecific. We absolutely must strictly audit the specific organ involvement. The real question is, are we dealing with the multi-organ inflammatory destruction of systemic lupus erythematosus or the progressive vasculopathy and fibrosis of systemic sclerosis? Now, think about the physical manifestations of that progressive tissue fibrosis. We're talking thickened, hardened skin on the hands. That's sclerodactyly. And notice the facial tightening, the purse string lips, the decreased oral aperture, right alongside those telangiectasias, which are those dilated blood vessels. These physical markers are screaming systemic sclerosis. But to truly lock in our diagnosis, we've got to look at the right serology. And this right here is where we find the true signal. We need the exact serological submarkers that differentiate these diseases way better than a simple ANA ever could. If it's SLE, a type 3 hypersensitivity disease, you're hunting for high signal markers like anti-Smith or anti-dsDNA, which is highly specific for renal involvement. Now, if it's scleroderma, we've got to divide it further. Limited scleroderma, think Crest syndrome, is signaled by the anti-centromere antibody and carries a very high risk for pulmonary arterial hypertension. On the flip side, diffuse scleroderma, which rapidly involves the trunk and proximal limbs, is signaled by anti-SCL70, and that one carries a devastating risk for interstitial lung disease and scleroderma renal crisis. Which brings us to a major executional trap. Let's say a patient with diffuse skin disease suddenly develops a rapid onset of high blood pressure and acute renal failure. What's your immediate reflex? For most autoimmune flare-ups, we instinctively reach for steroids, right? But is that actually the right move here? No. In fact, it's a dumb mistake. Corticosteroids are a critical, potentially fatal error in this specific scenario. Giving high-dose steroids, anything over 10 milligrams, actually precipitates or drastically worsens a scleroderma renal crisis. The definitive, albeit counterintuitive, execution here is the immediate initiation of an ACE inhibitor, like captopril. And yes, you do this even if the creatinine is already elevated. You literally have to shut down that specific pathway to save their kidneys. Moving right along to Module 2, muscle inflammatory vectors. Let's see how we can build a rock-solid diagnostic dividing line for inflammatory myopathies. Okay, so here we're shifting between direct T-cell muscle invasion and antibody-mediated vascular damage. Both of these present with symmetric proximal muscle weakness. We're talking patients having a really hard time rising from a chair or lifting their arms. That weakness, combined with an elevated CK, is the shared presentation. It's the baseline. To find the real signal, we have to differentiate between polymyositis, which is endomysial inflammation driven by CD8-positive T cells with zero skin involvement, and dermatomyositis, which is perimysial inflammation driven by CD4-positive T cells and B cells. And listen, you must audit the severity here. If it's stable, progressive weakness, your play is an EMG and muscle biopsy. But if you see weakness involving the oropharyngeal or respiratory muscles, that is an emergent signal, demanding immediate IV steroids and a swallow evaluation. Don't sit on that. The tipping point here visually reveals itself right on the skin. Dermatomyositis carries these exclusive high-yield signals. You've got the heliotrope rash, that purplish discoloration and edema right on the upper eyelids. And then there are Gottrin papules, those erythematous plaques overlying the knees or knuckles. If you see symmetric proximal weakness, plus these specific rashes, or even the classic shawl sign of erythema draped over their upper back, boom, you have your dermatomyositis signal. But wait, once you make that dermatomyositis diagnosis, your work isn't done, not even close.
You might be totally focused on initiating high-dose corticosteroids to treat that profound muscle weakness, but failing to look deeper, that's a massive execution gap. So what crucial underlying condition are you missing? You're missing the malignancy audit. Treating the muscle weakness while ignoring the systemic trigger is a catastrophic mistake. Why? Because dermatomyositis is very frequently a paraneoplastic syndrome. The absolute correct execution here is to immediately jump into age-appropriate cancer screening right at diagnosis. You actively need to screen for underlying malignancies, specifically lung, GI, breast, and ovarian carcinomas. Don't let this slip through the cracks.
All right, Module 3, the systemic aching axis. This audit tackles the structural pathway of diagnosing profound body aches, separating true, measurable inflammation from a central pain processing disorder. Both polymyalgia rheumatoida and fibromyalgia present with severe, debilitating, all-over aching and fatigue. If you're just listening to the chief complaint of, "Doc, I hurt everywhere and I'm totally exhausted," you are drowning in clinical noise. They sound identical. We really have to filter that noise out to find the structural reality.
And our tipping point lies right here in the demographics and the inflammatory markers. PMR classically strikes patients, often women, over the age of 50. They'll have profound morning stiffness in the shoulder and pelvic girdles, and their inflammatory markers are absolutely screaming. We're talking an ESR usually greater than 40 or 50. Fibromyalgia, on the other hand, that typically affects younger or middle-aged women with diffuse point tenderness and that characteristic cognitive fog. But crucially, their inflammatory markers, their ESR and CRP, are perfectly normal. That's your dividing line.
Since pain is the primary complaint for both of these, we have to navigate around another super common, yet highly damaging therapeutic mistake. When a patient is sitting there in profound pain, it's so tempting to reach for heavy-hitting pain relief, like chronic oral steroids or opioids. But honestly, does that actually work for fibromyalgia?
The short answer, absolutely not. Prescribing steroids or chronic opioids for fibromyalgia is a dumb mistake. Neither of them is effective, and both carry significant long-term morbidity. The correct execution for fibro is structured aerobic exercise, good sleep hygiene, and potentially targeted antidepressants like amitriptyline or duloxetine. Conversely, for PMR, low-dose prednisone, just 10 to 20 milligrams a day, yields an absolutely dramatic, almost miraculous improvement. It's like night and day. Section 4, the Sjogren's Pearl. We're going to close out this explainer with a high-stakes executional pearl regarding Sjogren's syndrome. This is the kind of stuff that truly separates the novices from the experts. The classic textbook definition of Sjogren's focuses heavily on the B-cell-mediated destruction of the exocrine glands. And yes, virtually all of these patients will report severe dry eyes, a gritty sensation like sand in the eye, and a super dry mouth. But if you stop there, you are just treating the noise. We've got to dig deeper. 40. That number represents a dangerously high risk factor associated with this disease that you simply cannot afford to miss. The true signal you must always be auditing for is malignancy. Sjogren's patients have a staggering 40-fold increased risk of developing B-cell lymphoma, specifically multoma. Think about that. So if your Sjogren's patient presents with a newly palpable, persistent parotid gland swelling or any new, persistent lymphadenopathy, the definitive execution is an immediate biopsy. You have got to catch that lurking lymphoma. It is absolutely essential to build this audit framework into your daily practice. Whether it's choosing an ACE inhibitor over steroids for a renal crisis, screening for lung cancer and dermatomyositis, or checking that ESR to separate PMR from fibro, you must be disciplined. Don't just react to the loudest symptom. Thanks for joining me on this explainer. I'll leave you with this challenge. The very next time a patient walks into your clinic with all-over pain and a positive ANA, are you going to fall for the noise, or will you execute on the signal?